one. All right. So here we are with Kieran Richardson, who you're based over in WA, right? In Perth?
Yes, yeah, I'm in the southwest of Australia in Perth. So
awesome.
Yeah.
Well, thank you for joining us East Coasters at a time that suits us, as opposed to you. I'm really pumped to have this chat, Kieran. It's a hot topic at the moment. It seems to be getting hotter and hotter and hotter by the week. So I was very keen to get you on to get your thoughts on this in this weird time of the coronavirus and everything. So video conferencing seems to be another hot topic as well. So let's get into it. So give us a brief intro about yourself, and then also how you came to be interested in the non-operative management of ACL injury.
Yeah, thanks for having me. So I work as a specialist musculoskeletal physio in Perth, and I run a consultancy company of academics and researcher clinicians, and we give second opinions to clinics in Perth and run mentoring and professional development for physios. And so I do that full time, and I have my own caseload of about 10 hours a week, two half days, where I see a lot of ACL injured patients for non-surgical opinion. And there's some failed grafts as well in there. So people that have gone through the surgery, they've returned to sport, it's ruptured. And then I'll see them for review and rehab. It all started for me when I was going through my specialist physio training, and I had two contrasting cases that really forced me to look into the literature. So I had this one case, and they were similar demographics. So there was this patient, she was in her 30s, and she was out late one night dancing under the influence of alcohol, and her knee gave way. And then she went to an emergency department and saw a specialist who decided to operate on her the next day. And then during that operation, in the operation notes, it says that the hamstring graft that they'd used was contaminated. So they put a Lars graft in. She wasn't given any rehabilitation after, and so her knee felt sore for about a year. And then they had a follow-up MRI, and it showed that she developed a cyclops lesion, which meant that her knee was stiff. So she had an arthroscopy for that, and it helped a bit. So she got a little bit more range and flexion. And then she had another series of scans which showed she had developed inflammatory arthropathy within her knee. And so the specialist decided upon, after feeling her knee, that her Lars graft was lax. So they did a two-part revision where they took out the Lars and then decided upon using a contralateral hamstring. As well as that, she had what he felt was a posterolateral corner instability. So they used the contralateral gracilis for a posterolateral corner reconstruction, and they did this revision of the knee. Unfortunately, after the first stage of the revision, she developed an infection where they took bone graft from her hip after a dog jumped up onto her hip. And then so she was, then she had antibiotics, which didn't help. And then so she was in hospital on an IV drip for a week. And then a couple of months later, she had the last part of the revision. Unfortunately, the day after that revision, she got up and her knee buckled, and she did a grade 2 MCL and near full thickness popliteus. So she came in and saw me in clinic on a 4-wheeled walker. So this is a patient that I just saw in practice, and she was weeping the entire consult, and she was in a lot of pain. And so I saw her, and we rehabbed her and got her eventually semi-functioning in about 1.5 years. And then while I was seeing her, I had this other patient who had a sporting injury where she was playing field hockey, the knee gave way, kind of classic ACL, and mild small MCL, small meniscal tear, sorry. She came in and said, look, whatever the scan shows, because she hadn't had a scan, I want to have, I don't want to have surgery because my friends have had surgery and it didn't work out so well.
Mm.
And so I looked a bit into the research, and I just thought, okay, well, what does the research show? Because I was going through this specialist training, which is big on translating research to what you would do in the clinic.
Mm.
And this patient, she was committed to the rehab, and then we just took her through based on, I guess, the best studies that were available, and she returned to sport in 4 months.
Mm.
And that was the first one that I'd done, which was about 6 years ago now.
Mm.
And after that, I guess I just had these two contrasts, and it forced me to look into the literature. So I would have spent, hundreds of hours just reading my own papers, reviews, and then I
Mm.
started interviewing research experts from both sides of the aisle, like
Mm.
surgeon research experts
Mm.
and physio research experts.
Mm.
Uh, and then I just started to realize we had a problem with over servicing
Mm.
of this technique in managing. Not to say that no one ever needs it, but
Mm.
just that there was no real resources for patients to access early non-surgical opinion, or even just that non-surgical is as
Mm.
good for many people. So that's just forced me to look into it more, and I now run workshops for physios, and I've seen hundreds of patients using this sort of approach.
So the light bulb moment was this two very opposite outcomes, which is kind of how it happens, doesn't it? A light bulb moment comes with clinical practice, and you see differing outcomes based on. To be honest, if you'd have run those two scenarios and didn't say the intervention that they had, most physios would say the one who got back to sport quicker was likely the surgical one, I'm sure. So this is the
Yeah,
cultural
exactly.
norm, right?
Yeah, and that's the thing. It's just so. I guess you're right. Like, it was I guess an epiphany or a light bulb moment. Like, I hadn't even thought about. I just assumed. I'd never thought critically about whether it was the best approach. I just assumed surgery was better, and this is coming from an experienced physio. I just sort of had assumed that the research would be quite obvious on it, and then the deeper you look into the research, probably similar with what you'd find with the shoulder, what you start to see is there's this commitment to a pathoanatomical approach that maybe isn't necessarily founded in good evidence. And then patients are told things that this is a new ACL. This is a minimally invasive technique. This is the gold standard. And there's these kind of euphemisms that they're presented with. But when I just started asking the question, well, okay, well, is there actually research that shows that a structured exercise program is going to make patients worse off who have an ACL tear? Or, is there actually good science to show that doing rehab is going to, be detrimental? And you start thinking, okay, well, if the best studies aren't showing that that's true, then, maybe we've got a problem.
There's a conspiracy on our hands, that's for sure. But I mean, conceptually, it makes sense, doesn't it?
Yes.
And this is the problem with pathoanatomy. Not the problem, but this is why it's such an appealing model, right? You tear something which is imperative for what we were taught, the functional stability of the knee, and I can extrapolate to the shoulder for a rotator cuff tear as well. You correct that, and then you go on as you were. Correct? So you can understand probably why we have sort of gone down this pathway, but here we are 50 years later, potentially, or even more. I don't know. When was the first ACL surgery done? 100 years ago?
So they started doing ACL reconstructions in the early 1900s, and they've done all sorts of ACL reconstructions. So you've got obviously the ones that we know now, the hamstring or bone patella tendon bone, but they used to use the meniscus for some patients. They used to use the ITB for some patients. They've used different animal models, and there's a paper after a famous AFL player, well, fairly famous for his 12 ACL surgeries, Alex Johnson from the Sydney Swans. So after he did his, he had 5 reconstructions and then a further 7 ops because he developed an infection. And you'd think, after maybe the first or second that they'd be thinking differently. But so there's this group now, I'm pretty sure on the East Coast, that are advocating for kangaroo tendon to be used in human subjects, which I actually thought when I first read the article was a satirical piece. But then the more I looked into it, and the lead researcher says, look, the marketing is easy. People are always asking us to put extra hop into their step. And I thought it was a joke.
Not literally.
And as a New Zealander, I thought this was a joke. Like, I was like, is this a joke? But it's true. So there's these people, and you're right. Like, conceptually, it does make sense. The problem is, it's a series of logical fallacies. So whenever you take a drill and put it through someone's bone structure, it does something to the bone structure that's different to not doing it. And I can mention studies if that would help the listeners, or the viewers. But there was a paper by.
We might come to that in a minute. Yep.
Yeah. So it's basically when they drill the tibial and femoral tunnels. It softens the joint cartilage, creates microfractures. It punctures into the joint. So when you have an ACL injury, normally it's intracapsular, but when you come in with a drill into the joint, it changes the joint environment as well and creates more synovial inflammation. And then you're taking a tendon, typically hamstring in Australia, which doesn't have a ligament. It's not a ligament. And so then you put that in to the joint. And if you look at an ACL normally on an MRI, it's like the size of your thumb, but a graft is like the size of your pinky. And it never has the properties, even at 4-year follow-up, of a ligament. So hence the re-rupture rates are fairly high. And so conceptually, yes, it does make sense. This is a new ACL, but it's not a like for like. And then you start to go, okay, well, what is that doing when I'm having that technique plus exercise versus just doing exercise? And so for physios, that makes sense. It's like, okay, yeah, we would just wait for a joint to settle down. We would start applying strengthening, look at motor control deficiencies and what the patient's psychology is like. And then are they fear avoidant? Have they strengthened condition before? But if they're just told based on a scan, and even this week I've had a couple of patients that because of the coronavirus, they're stopping elective surgery, but some hospitals, and it's come out in the media, are pushing patients through for debatably urgent elective surgery. And they're told, look, based on your scan, you need this procedure, but there's no sort of scientific evidence to say that, scan alone is what we need to treat a patient.
Yeah, wow, it's far out. It's a bit of a dark web, really, isn't it? When you go into it, and it probably just gets deeper and deeper and deeper. Let's touch on some of the evidence. So, I think came across some contrary evidence for the ACL reconstruction 2 or 3 years ago when that 20-year follow-up study came out. And then it showed no difference in osteoarthritis outcomes, which flummoxed me. It was befuddling. I couldn't believe it. Didn't make sense, right? How can you have an unstable knee that's not wearing out quicker versus a stable knee? So then being a shoulder man, I didn't really go too deep down it, but that was quite interesting. So do we have good randomized controlled trials where we have a group of non-operative versus an operative group and we follow them through? Yeah.
So probably, I guess the first point I would say is there's that, you spoke about like the intellectual the dark web. And it is actually, it's not a conspiracy. It's actual fact that there was a systematic review by Kay in 2017, and there was 411 RCTs that compared surgery to surgery, right?
Yeah.
But there's only one study that compares exercise to surgery and exercise.
Mental.
It's mental. And so that's why Cochrane, in all their reviews, pretty much for the last 20 years, have said there is no scientific evidence to say that people need early ACL reconstruction. And it's basically just become this healthcare system supported process. And so from an RCT point of view, the RCT is the Canoon trial, which people can look up, and it's got a 5-year follow-up with a 10-year follow-up coming out this year, which might crash the internet. And it's at each point, at 2-year follow-up, at 5-year follow-up, and I know I can say it now. The authors have come out and said it, although it's not published yet, but they've said it through conferences and online, that there is still no differences between the groups. So then,
across what measures are we looking at? Structure? Are we looking at functional outcome, pain, everything?
Every measure, literally every measure: pain, symptoms, mental health, quality of life, return to sport outcomes, and these are in highly active, near elite, so kind of A-grade amateur. The typical patients that would have a reconstruction, 18 to 35. And so this is the paper that has turned everything on its head in our thinking. And it was very balanced, written by 2 surgeons, 2 physios. And if you listen to British Journal of Sports Medicine and their podcast, they're just like, look, we just wanted to be open and honest. And so we started the trial, and in the late noughties, people were coming up and patting us on the back saying, look, this is great that we can finally prove that reconstruction is the superior strategy. But then the same people, when the 2 and 5-year follow-up results came out, were not welcoming. They were openly hostile, is how the researchers say, because it didn't support not only the narrative, but practice.
Yeah, mate, it questions their whole identity, worldview, all of the above things that we don't want to have questioned, Kieran.
Don't shoot the messenger. I'm just trying to. I'm trying to help people.
Fault. All your fault. So let's talk about. So that's the Canoon trial, correct? Yeah. So when was that originally? So it's 1 year, 5 year, 10 year, or what are the?
So it was collated in the I think from early to like 2004. I think they recruited, and it took quite a few years to get the subjects. And then they published the 2-year follow-up in 2010. And this is the first trial that's compared it could be maybe more specific in terms of the exercises. It's quite general, but the other cool thing was, yes, there was a protocol that people had to, the patients had to go through, but there was pragmatism in the sense that the therapists could add in exercises as they wanted, which was pretty cool. So the 2-year follow-up came out in 2010. And then the 5-year follow-up came out in 2013. And then they've since done a series of prognostic analyses on the Canoon group. And they've found that, so there's an Australian researcher actually from Queensland, Stephanie Filbay. She did it was like an award-winning review in prognostic analysis in 2017 that showed that patients that have early Reco before 10 weeks across every measure at 5-year follow-up are prognostically worse. So this is sort of further reason. So I guess my key message out of today is that, like any other soft tissue injury, we should just wait 3 to 6 months, give the patient their options, and then just commence strengthening and rehab like we would with anything else. And then if the patients have like a locked knee, if they have an associated meniscus tear, or if their knee continues to buckle despite high quality strengthening, then they become a surgical candidate. But if we don't give them the option, and then if they don't complete the rehab, we kind of never know.
Okay. So what you're saying is essentially that an ACL rupture occurs, that person should then go down a mandatory 3 to 6 month rehabilitation regime. If they were to
Yes.
fail that or I don't like saying fail that, or be unhappy with their outcome after that,
Yeah.
then they can choose to go on and have surgery. It shouldn't be ACL rupture, surgery happens, but
Yes.
only if you really want to, you can try rehabilitation. Is that
Yeah.
correct?
That's a great summary. There's an emeritus professor of orthopedics, so he mainly does trauma, but he is a world expert in knee OA, and Stefan Lomander, and he was the senior author on the Canoon trial. So Frobel, who I've interviewed in person, he was the physio researcher who actually was the lead. It was his PhD. But then the senior author, Stefan Lomander, I met him when he came to Perth last year. And I asked him, I said, like, what do you tell patients? And he goes, I give every patient 6 to 12 months of physio, because I can't promise as a surgeon, if I operate on them, their knee will be any better afterwards. So he takes a very, non-invasive approach, and sort of, like you said, the patients have to be willing to commit to it and open to the idea. One other point, this is all assuming the ACL doesn't heal. So when we went through, based on animal models, the understanding was that the ACL has a poor capacity to heal because of its blood supply. Now, there's been, since the mid-90s, there's been about 10 or 12 papers that show, in fact, the ACL can heal, particularly when we apply strengthening to it. So there was a paper which, you could pass on to the group or share on your socials, but it was a Japanese study in 2017, Ihara and Kawano. And I'd encourage you to reach out to the authors, because it blew my mind when I read it. But they had 102 patients who all sustained full thickness ACL ruptures, plus minus concomitant injury. And 83 of the 102 healed at 12-year follow-up. So this group, what makes this different is they applied strengthening to the knee. So every patient was put in a brace for 3 months, and they started strengthening within 3 weeks.
Okay.
So that's
crazy. So there is okay. So the people whose ACL has healed or show signs of healing, do they do better than those who haven't? So is the healing essential, or is it something good that happens potentially?
Yeah, I think that's a good question. So for me, I just had a lady yesterday, I see quite a few ACLs now, non-surgical opinion.
I can imagine.
So I tell them, look, it's great if it heals, but it isn't essential. In fact, I don't encourage a follow-up MRI. As you would know with the shoulder research, if MRI tends to increase rate of depression, focus on the injury itself, fear avoidance behavior, increased rate towards trajectory towards surgery. So I just go on signs and symptoms if I was to boil it down. And I find the patients that kind of settles them down, and they're not so stressed. But it's a very cool myth buster. And I've had 4 or 5 in clinic, and I've posted them on my global specialist physiotherapy group, where we are online. And there's one case we had in Perth here. She was a 16-year-old netballer, fairly high level. She ruptured her ACL. She was booked in at 3 weeks, but fell sick. And then when she delayed it, and a physio who'd come on my workshop kept rehabbing her. Surgeon delayed it till 6 weeks. Then she had her ATAR exam, so she cancelled it again, and she felt awesome. And so they did all the return to sport testing. She was fine. Returned to netball in 9 weeks. Has been totally fine, asymptomatic, with a 2-year follow-up. And she had a 6-month MRI, which showed complete healing after a full thickness rupture. So it's awesome. And it's that, I think, if in an ideal world, if we could kind of, not tell the patient the result of the scan, but, depending on whether it heals or not, work out some, system whereby we could de-threaten it either way. I think it could be useful to get an MRI. But it's just a great, like that's the sort of, the healing paper is what I use with elite athletes, because they're just they're in a almost a whole nother ball game. Like the media pressure and the the pressure from the clubs, and contractually there's pressure. So it's you see them having a selfie, the next day after their injury in their surgical gown, like they're already prepped for surgery. Like it's just this kind of caricature that we see.
That's a completely different conversation, isn't it? Let's not get into the shortcomings of elite sport medical management. Anyway, so if I can summarize, I know you have to go. So
yeah,
ACL management or non-operative ACL management. Let's just say that there's never been any evidence to suggest that in a randomized control trial that a surgically repaired ACL is superior to a non-operatively managed ACL. True?
That's true. And I'm not saying that no one ever needs surgery like that. Definitely, I'm not saying that. But I'm just saying, particularly now with the coronavirus, the elective surgeries are cancelled. So what are we meant to do with these patients on the wait list? It's kind of the perfect opportunity for them to get rehabbing, with telehealth. And I'm actually just did one before this. I had a patient in far north Queensland. Wednesday, I had a patient in southeast Queensland, guy in Saudi Arabia this afternoon, and next week people all over the world. It's they're kind of, well, they can't have an op, so it's almost hand of God forced to not, So
you offer telehealth stuff online. So tell us exactly what you offer, Kieran.
So, well, for physios that are listening, I do online courses that are you can check out at globalspecialistphysio.com/ACL. So there's courses that you can access through there. For patients, I do second opinion reviews, non-surgical, via Zoom like this or Skype, and I found them to be very successful. At the very least, it's an education session, so they can be informed of their options. But a lot of the patients will go on and just do, education and exercise facilitated through me.
Excellent. And do you demonize open kinetic chain exercises for the knee, or where are you at with that?
I'm all right. I'm okay with it. I think the end game is always function, and so I'm really interested in getting if their job was sitting down at a chair straightening their knee all day, then maybe that would be one of the exercises I'd give. But I'm not like, if there's no ACL, assuming it doesn't heal, then it doesn't matter. There's no studies that say it's detrimental. So I'm happy if people want to do it, but it's not my go-to exercise, I guess.
Awesome. All right, mate. I'll let you get back to saving the ACL world, and have a good day. Stay safe from all this mayhem that's going out there. And thank you very much for your time. I'm sure people will get a lot out of it.
Yeah, cool. Yeah, no worries. Yeah, it's good. I love talking about it, and yeah, there's much more to unpack. So I'm happy to do more sessions in the future if you're keen, and
I'll take you up on that.
Yeah, not just a little. That's just a little snippet.
No, totally. There's about 14 other questions I have written down that I want to get through. We were handicapped by technology today, so definitely let's sit down and do something else again in the future, mate.
Cool, mate.
All right, Kieran. Cheers, pal. Take care,
cool.
Man. See ya.